Welcome, everybody. How can we save 340,000 women's lives a year? This is a question that we're going to investigate today on this CUGH panel webinar on how can we eliminate cervical cancer. I'm Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health in Washington, D.C. Cervical cancer is the fourth leading cancer amongst women. And as I said before, it kills 340,000 women a year. Moreover, more than 600,000 women are diagnosed with cervical cancer annually. But its distribution is not even. It primarily affects the poor and women in low and low middle income countries, where 90% of deaths from cervical cancer occur. This doesn't even account for the sea of grief and humanity that this causes, not only with the loss of women, but the loss for their children and their spouses. It's an unimaginable problem, but the good news is that the cause of cervical cancer, human papillomavirus, can be detected, prevented, and cervical cancer treated. In this panel, what we hope you'll do from our extraordinary panelists that I'm going to introduce in a moment is take what they're going to share with us, take it home and implement it. Because if we can do that, we can surely drive cervical cancer numbers down and work towards the elimination of this terrible, terrible disease. Now today, our first speaker is Dr. Maurizio Mazza. Dr. Mazza is the Regional Advisor for Cancer Control at the Pan American Health Organization. Then he'll be followed by Dr. Gina Ogilvie. Dr. Ogilvie is a professor at the School of Population and Public Health at the University of British Columbia in Canada. He's the acting director of the Women's Health Research Institute and the senior public health scientist at the British Columbia Center for Disease Control. Then Dr. Patricia Garcia. Dr. Garcia, a longtime friend and a new board member of CUGH, is Peru's former Minister of Health. She is a professor at Cayo Tenerife University in Peru. And then finally, Dr. Ted Trimble, another longtime individual who's been a great supporter of CUGH in our work with cancer in the National Cancer Institute. Dr. Trimble is a senior advisor for global HPV and cancer and cervical cancer control at the National Cancer Institute in Washington, D.C. So again, over to you, Dr. Mazza, and please get your questions ready, because at the end of this, you'll have a chance to post your questions in the Q&A, and we will post them to the panelists and who will be able to answer your questions. Dr. Mazza, over to you and welcome. Sorry, Dr. Mazza, you're muted. You're muted.
Thank you. Thank you so much, Dr. Martin, for the introduction and allowing me to share a little about the experience on the development of the elimination strategy for cervical cancer. Please let me know if you can see my screen now.
Yes.
Okay, thank you. So to begin with, I want to share a little about the different initiatives that WHO has regarding cancer prevention. The first initiative that was launched was the Cure All initiative for childhood cancer. Secondly, in the midst of a pandemic, the global strategy to accelerate the elimination of cervical cancer was launched. And most recently, the Global Breast Cancer Initiative. As you can see, cancer is one of the main priorities for the World Health Organization. But as Dr. Martin said, unfortunately, in the case of cervical cancer, there's a huge variability of incidence rates around the world, not only incidence, but mortality rates, with sub-Saharan Africa being mostly affected by this disease, also related to the prevalence of HIV women that are at a higher risk, while different countries in North America are very close to getting to that elimination threshold. While in our region specifically, which one I'm going to share with you today, the Caribbean, South America, and Central America, they find themselves in the middle of this. But unfortunately, even within our region, cervical cancer, it's a huge public health problem. As you can see here, if we see the ranking of the most common causes of cancer incidence in women, we have that it's top two causes in many of the countries in Latin America, the Caribbean, and even more cause of mortality. So we know that in our region, there's roughly 60,000 cases per year. But if we don't do anything about this, it'll significantly increase through time. And it is because of this and what we face, an example in our region, but as I said earlier, even more in sub-Saharan Africa and other parts of the world, that the World Health Organization launches the global strategy to accelerate the elimination of cervical cancer. This is the official document, but besides that, in the last couple of years, there's been a lot of development on different materials, guidelines, and support that help countries reach those goals. So what are those goals? What's the elimination strategy overall? So we want to reach an incidence of less than 4 women per 100,000. And for that, we have 3 pillars, the 90-70-90 pillars. First, 90% of girls fully vaccinated by the age of 15. Then we have a 70% of screening with a high performance test, which currently the most widely validated one is the HPV test by the age 35, and then again by age 45. And finally, to ensure that there's a proper treatment and follow-up of 90% of women with an abnormal HPV test with pre-cancer all the way to invasive cancer and palliative care. I'm going to share with you what the advances have been within our region at PAHO. And as you can see, fortunately, most of the countries have already introduced the vaccination in the region, but we can see that it has been introduced, but the scale varies from one country to the other. If we look at the last 3 years, in 2019, we had approximately 50% almost of the countries getting at least to that 50% coverage of the vaccination. Of course, we can see a significant impact on that in 2020. A lot has to do, of course, with the COVID pandemic. And then in 2021, we were able to gain a little back. But the good thing is that we know that it can be introduced. We need to ensure that we continue our efforts on the vaccination and to shoot for that target so we can reach that goal by the end of 2030. When we look at screening with a high performance test globally, we can see that in this case, there's different screening mechanisms, the conventional cytology, leukoid-based cytology, visual inspection with acetic acid, but the HPV testing. And again, we can see that unfortunately countries where cervical cancer is not the biggest burden are the ones that are turning into that dark blue, which is the HPV testing, while countries that really need this are not through that. And many countries in the region are in a transition of going from cytology-based screening to HPV testing. Now, there's a lot that we need to do to get more information on what actually is available. I'll put, for example, in as a sub-region in the Caribbean, we know that many countries are doing cytology-based, but we need to do that transition from cytology or VIA to an HPV testing, and then to actually work with the countries and have those indicators for follow-up, because we don't have all that information for most of the countries. What we do know is that there's a lack of access in many countries, as you can see here, to tertiary care for women that actually have cervical cancer. So we really need to work on how to improve radiation therapy for many of these countries and palliative care that there's a great need. Very quickly, just one example of something that PAHO has collaborated directly with a state member is supporting on the transition for the introduction of HPV testing, and that's the case of Antigua and Barbuda, when we work closely with an implementing partner, which is Basic Health International. And we've seen that transition, that they're currently finishing their pilot as we speak, their first 1,500 women using a technology that now almost all countries are familiar with or have strengthened through the pandemic, which is HPV testing through biomolecular testing, in this case with the expert. And here you can see we're meeting with the ministers and with different members of the Ministry of Health and the task force of Antigua and Barbuda, as they've worked all together to make this a possibility in College from Basic Health. Now, as from PAHO, we have a plan of action for cervical cancer prevention and control that actually came before the elimination strategy. I can share with you the link to that so you can access it and see that we see this also from the health promotion side, vaccination, screening, all the way to treatment as part of our key indicators for success to be able to prevent and eliminate this disease and be on the path towards that by the end of 2030. There's a lot of challenges in many countries. There's a lack of surveillance in systems, fragmentation of systems. We need more support on research, limited access to medicines and treatment, but we have opportunities we have a lot of support from civil society, different organizations that are present to make this possible. There's a lot of political will that's increasing through the countries because of the initiative. We have a strategic fund that can support with the procurement of materials and consumables for HPV testing. And we have also a fund that supports vaccination and the medicine for women that need it. The good thing is we have clear guidelines on steps to follow moving forward to the elimination of cervical cancer. Thank you very much for your time. And with this, I will pass the talk to Dr. Ogilvie. You could please.
Thank you. Thank you. I'm share my screen. Thank you. So thank you, Dr. Maza, for such a great introduction. And I'm going to keep just the conversation going, and I'm going to focus on the screening element of eliminating cervical cancer. So we know that cervical cancer can be prevented through these three pillars: vaccination, screening, and treatment. And as Mauricio just showed us, WHO has made these 90-70-90 goals, which I think are really great and helpful for us as we strive to eliminate cervical cancer by the end of the century. I'm going to focus on screening today, and we have this great data from our colleagues Karen Canfell and all, who have looked at what happens if we focus only on vaccination. And certainly we will get to those elimination targets if you follow that blue line where we vaccinate alone. However, if we add screening, you can see that we still get to the elimination targets, but we save substantial amount of lives. And Keith started out by talking about the number of lives saved, and certainly just even to the end of the decade, by focusing on screening coverage as well as vaccination, we can prevent hundreds of thousands of deaths. Yet, despite this, there's only an estimated worldwide coverage of about 15% of women have been screened in the previous year and 35% in the past 5 years. And over 67% of women globally have never been screened for cervical cancer. So there are important innovations that can support the broader coverage of cervical cancer screening coverage. And Mauricio has just alluded to it as we talk about HPV-based high performance testing. And some of the innovations that element that will improve coverage include that HPV testing can be self-collected. So women can get the specimen themselves. They don't necessarily need to attend to a practice or a clinician. So that means samples can be collected anywhere. The person can easily do it themselves, by themselves. They don't need a practitioner, and it's very accurate, safe, and painless. So we have this innovation that will allow us to improve coverage rapidly and very effectively. So, should we focus on deploying cervical cancer screening in resource-limited settings? And the answer is yes. So I want to just share some of the innovations that we can deploy and some of the evidence around the fact that we can effectively deploy self-collection in resource-limited setting. So we've been working with our partners at Uganda Cancer Institute, and particularly Dr. Carol Naksiga and Dr. Jackson Arem at the UCI, to look at ways to improve coverage of cervical cancer screening in a low resource setting. And we've been working in Uganda, which has one of the highest rates of cervical cancer in the world, for over a decade. And we've been working particularly with the Uganda Cancer Institute, which is the centralized cancer center and where folks can obtain treatment. So over the past decade, what have we found? We found that women are very willing to self-collect and provide an HPV test. We found that although embarrassment with self-collection is a concern, that there are ways to overcome it by focusing on the value of screening and particularly the prevention element of cervical cancer screening and self-collection. We found that males and male partners are a critical part to supporting cervical cancer screening for women, and indeed that the men are very supportive of cervical cancer screening and keen to know how they can help their partners obtain screening and treatment. We've learned from our community-based pilot projects that we can effectively deploy screening, we can get the tests to the lab, and that we can get results to women in an efficient and accurate manner. And we've also shown in a randomized trial that when you offer self-collection versus VIA, that women are substantially more likely to take up self-collection than attend to VIA, really showing that self-collection can improve coverage. We've also done a series of cost-effectiveness examinations that show that self-collection is deeply cost-effective for a health system. And finally, and I'll discuss these today, we have looked at ways to effectively deploy screening in a rural setting, and I'll just show you what we found with that. So our data comes from the Mayuge district of Uganda, where less than 5% of women have ever been screened for cervical cancer. So what are the first things we need to think about if we're looking at deploying cervical cancer in a region? You really need to examine what are the preferences for both the healthcare providers and for the women in order to facilitate coverage of self-collection. So what we found in Uganda was that there was a high awareness of the need of cervical cancer, that we had laboratory staff that were skilled and able to deploy high performance tests. We had deep interest by the nurses and the midwives in building their clinical skills to do VIA treatments and to do thermal ablation treatment, and that it indeed was a priority of the UCI and Ministry of Health to improve service availability. However, the women and practitioners also identified some barriers, which included misinformation about cervical cancer, challenges with transportation to get to clinics once self-collection had been completed and if women needed treatment, that there was a concern expressed by the women that about the quality of treatment care. There was concern about the long wait time. And while there was deep interest by the nursing and midwifery staff to develop their skills around VIA, that the human resource challenges, particularly health human resource challenges, were real and were a barrier. And finally, that we found that there was a challenge with specimen transport. So one of the things that's really important, and Maurizio talked about the need for research, is that when you do research in LMICs to understand how to better deploy and improve coverage for screening or for any health intervention, it's really important it be deployed within the health setting. So the work that I'm about to show you used local community health workers. We used GeneXpert, which was the preferred molecular testing by the Ministry of Health because they've already deployed it for HIV and TB. We trained employed lab staff and nurses so that expertise remained in the health system. And we used local health centers and collaborated with the MOH through the Uganda Cancer Institute. So this was a sequential pragmatic 2-arm cluster randomized trial where we looked in 31 villages in Mayuge district to look at how to improve cervical cancer screening coverage in rural Uganda. And women who were 25 to 49 who'd never been screened were eligible. There were basically 2 arms. One was a door-to-door self-collection. The other was community mobilization days where women gathered for a day and provided self-collection. So what did this show, and why is this relevant globally? We found that it was very feasible to integrate self-collection into existing health systems. Both arms had high rates of screening, but there was higher rates of follow-up for treatment in the door-to-door arm versus a village health day. But the village health day allowed us to bundle other services and requires less personnel. So what does this tell us, and what is the overall takeaway? It's that screening is a critical part of cervical cancer elimination, and that the innovations we have, particularly around molecular testing, offer us a really exciting opportunity to facilitate rapid deployment of screening coverage in low resource setting. But as we showed here, you do need to do country and region specific examinations to really ensure that the programs are tailored for each region. So as Mauricio showed in the Caribbean and in South and Latin America, there may be important differences. And so we really need to conduct that operational research to make sure that programs are actually grounded in the needs and responsive to the needs of the population. So thank you very much. And I'm pleased to be able to hand it over to Dr. Garcia to give us her presentation. Thanks very much.
Thank you so much, Gina. And I think this is great because it looks like if we have prepared it. So we have heard the introduction by Mauricio, and then Gina started talking about why screening is important and the experience on if it works or not in a setting like Africa, using some new technologies. And what I would like to talk, it's the experience that we have had in Peru, and try to think about how this could help, because the question is, how can we address this global problem? In Peru, one woman dies every 5 hours with cervical cancer. And women for each woman that is diagnosed, we diagnose at least 12 new Peruvian women with cancer every day. So for every 2 women, 1 dies. So this is incorrect, but anyway. So for every 2 women that are diagnosed, 1 dies. You have seen some data from Mauricio that said that in Peru, it is the second most common cancer. But one of the things, analyzing the data from the burden of disease from IHME for 2019, actually cervical cancer is the first cause of death in women in reproductive age. So another problem that we're having is data. The registration is very centralized. The cancer registration in Peru is very centralized and represents mainly what happens in Lima, which is the capital city, which has 1/3 of the population. But we're forgetting what is and ignoring what is happening in the rest of the country. And indigenous populations and those affected by poverty and social deprivation have worse health indicators, because the cases are concentrated in those most vulnerable regions and populations. Most women are diagnosed or treated in advanced stages, and that explains why half of the women die once they are diagnosed. And women with abnormal pap smears are lost to follow up. So the challenge is, how can we move from describing all these gaps to solving them? So new technologies are really give us some hope, because when they are appropriate and accessible, they could catalyze changes. But there are other things that we need to take into consideration. We need to improve health literacy. And when I talk about health literacy, I'm talking about population, communities, health professionals, and even policymakers, because we have to break myths. There are myths that, like that cancer is always a death sentence and nothing can be done. And so that end up, as a result, policymakers rather use the money in other things. The ways cancer has been presented shuts the public deliberation. So we really need to change that. We need to involve communities, institutions, governments, and global researchers changing this and giving hope again, because there is something that we can do with cancer. Health systems are not prepared to deal with cancer. So we need to start addressing how to redesign health systems. How can we retrain health professionals? How can we identify those incentives, those perverse incentives that don't allow us to make changes and are keeping the things the way they are. And how can we identify those incentives, the good ones that can promote change? And how can we strengthen primary care and assure a continuum of care, quality, access, and competence? So with all those questions, we decided to take the challenge and see if we could work in an Andean region of Peru. This is Cajamarca. You can see it's called the Swiss of Peru. It's really beautiful, but has one of the highest rates of cervical cancer. And actually, our project was called HOPE. And this is a follow-up because we have been trying to work on how can we do something that will make a difference. And as Gina said, we know already that in Peru, HPV test can be used. It's already on the policies. We introduced them in 2017. Women in the coast really loves to do self-sampling. So what can we do in the Andean region? So we decided to do this study, introducing new technologies to catalyze health systems redesign. So number one, using self-sampling with HPV with molecular testing that empowers women from the community to talk to other women to do the test, and empowers women in taking care of their health in their hands. The second is working together with Duke University, with Dr. Mimi Ramunajan. We introduced this pocket colposcope, but actually we didn't call it colposcope because physicians were against that anybody who is not a gynecologist to use a colposcope. So we call it an improved BIA device that comes also with the cell phone, with a Kala, with an app that is called the Kala Health. So this pocket colposcope allows to do really a visualization of the cervix, but also allows saving patient information, remote connection with experts. So we introduce the tele-VIA, and we can have the images seen in real time by the expert. We can save them, we can do quality control, and we can do training. And we add to that the thermocoagulator that is now recommended by WHO as a way of treating those lesions that can be treated, especially at the first level in the primary care centers. And the other thing is that we introduced also a very simple informatic platform to follow up the continuum of care, assure the adequate management at the first level, and the references to other facilities if needed. And we introduce also the concept of the patient navigator that we never had in our country. And I think in the US and other places, they use it sometimes. So we decided to put this all together. So in this redesigning of the health systems, and you have the pyramid there, we decided to start this pilot study, actually the feasibility study, in which the self-sampling tests were distributed in the community by women, but also by professional, well, actually by community workers that had to go to the community at least once a week. If women was HPV positive and the women are sent the results through SMS messages through their cell phones, if women were positive, they will have automatically a appointment to the clinic to one of the primary health centers where they could be seen by midwives, professional midwives, or general practitioners who are trained and are using this enhanced VIA pocket colposcope. And if any women had no criteria for thermocoagulation, because in general they receive the treatment here, but if they cannot receive the treatment, they are referred to the second level, or women with advanced lesions are referred to the third level, that is the regional hospital. And in all the cases, we follow the women with this HOPE informatics platform, and the patient navigator will be always near her. So we work with the regional government of Cajamarca from the very beginning to plan together the intervention, to try to see what were the gaps, what was possible, what do they think that we could do. And we always work in the type of research that I do, that is implementation research, with the Ministry of Health that cares for 70% of the population in the whole country. So we also had meetings with the women from the community to understand their needs, their difficulties, and because they were going to help us to talk about these type of tests and cervical cancer. So we created this type of training and implementation plan that goes step by step, starting by creating awareness, training those that are going to distribute the test, training the first level, the second level, and the third level, including trying to understand what will be the expert specialized referrals that will be needed. And again, with the patient navigator and the information. So you can see here on the left, a woman teaching another woman how to put the swab into the tube, and they are in the market. Then we have the training of the midwives, and then women waiting in the waiting room, doing the tests. And on the other hand, you can see here in Lima, the expert, and we were teaching a group of experts here in Lima, how the images were looking, and they were giving recommendations in real time to the midwife if they should be doing the thermocoagulation or not, or the patient should be referred. So far, this was supposed to start it in 2020, but the pandemic stopped everything. So instead of being a 4-year study, it was reduced to a 1-year study. So we started in 2022. We decided to reach about, all the women that we could, close to 4,000 women, found a prevalence of 14.3%. 97% of the women that were HPV positive went to the appointment at the primary health clinic, the first level. 76% completed their treatment at the first level, which means that they received the thermocoagulation, they were seen a second time, and they know that they will come in a year or so. 2% are still waiting due to pregnancy, and we had to refer about 15% of the women to the second level and 4% to the third level. But so far, 87% of the HPV positive women have completed their treatment at health establishments from the first to the third level. So they have completed all the way, including having hysterectomies. And this is from March to December of 2022. So the introduction of new technologies can really catalyze health systems redesign. And what we were aiming was to assure empowerment of women, competence, integration, continuity, and completeness of care of the health system, which means quality and also equity. So now, thanks God, we have been able to, actually the government of Cajamarca is so enthusiastic about this because we have been working with them every day during the past, since 2020, we were preparing things, waiting for the pandemic to stop. But in 2022, we have been working very closely with them. So we're going to continue working with them on policies and ways to fund this and giving them technical support in order to scale up this in the region. This region has about 1.5 million people. We are also creating an extension of ECHO. ECHO is a program that is called Extension for Community Healthcare Outcomes, connecting specialists to improve the care of women. So with Peruvian specialists and international specialists, we're going to be discussing difficult cases and trying to find ways so women will not be left alone and physicians will learn how to manage difficult cases too. So this is our plan. And now I just want to finish with this slide, okay? Because we are going from research and we're moving into policy and action. And actually, this is what I have been doing through my life. And I'm very excited that I think we are reaching that point with cervical cancer and other regions are seeing, we're working with the Ministry of Health also at this point. So not only the regional government, but the Ministry of Health and other regions are seeing Cajamarca as a model to see what they could do. So first of all, it's important to engage stakeholders as peers from the beginning and during all the study phases, because that's the only thing that they are going to own the agenda. Ownership of the agenda is critical. We have to dissipate tensions between the stakeholders, because once you show them that things are not working, everybody gets upset. So in order to do that, you have to meet, you have to discuss, and you have to identify champions, and also to try to get together and discuss possible solutions. You have to train according to the needs. and guide that training by baseline and follow-up information. We decided to do this step-wise training because that's something that we discuss specifically with the government. You cannot put together midwives, general physicians, and OBGYNs. You have to do it separately. I mean, they have their own beliefs. You have to provide monitoring, technical support, and recognition. And actually, in December, we recognized those that distribute the highest number of HPV tests. And you know what we gave them? Certificates that were made on it was copper, silver, gold, and platinum papers. And they were so happy. And so the recognition is not necessarily money. It could be the recognition that they are doing a good job. We have to share results and discuss actions together. We have to consult and get feedback from the users. And we were talking very often with women to understand what were their needs and how to make things better. We need adequate technologies that can catalyze changes. And we need to involve other partners, collaborators, like we're working with the University of Duke University. Now we are starting to work with PAHO. We're trying to see what will be the ways to really assure that the country or the region can buy the tests. And we have also to work with the communities. We have to use friendly cost-effectiveness analysis. Cost-effectiveness analyses are very important for politicians, especially for the ones that are going to give the money, like the Ministries of Finance. And finally, we have to keep the motivation high because changes take time. And I think this is something that we have to work also with funders and with policymakers, and sometimes it's not that easy. So this is what I wanted to bring to you. And now I would like to invite Ted, Dr. Trimble, for the next talk. Thank you so much.
Thank you so much, Dr. Garcia, for that excellent presentation. It's exciting to hear about all the work that's being done in so many countries around the world to try to make progress on cervical cancer. Let me. So what I would like to speak on today are three topics. First, progress toward HPV vaccination. Secondly, universal health care, coverage for cervical cancer control, and then thoughts on what needs to be in place to diagnose, treat, manage symptoms, and encourage healthy survivorship for women diagnosed with invasive cervical cancer. So in terms of HPV vaccination, we know one of the major issues is having an adequate supply, and there's been a shortage over the last several years. A number of countries wanted to implement HPV vaccination, but we didn't have enough supply. Another issue is price, obviously, at what price the ministries of health were able to buy the and we hope both the supply issue will be resolved somewhat, in part because we now have data from a number of both prospective and retrospective studies that one dose is as good as 2 doses. And the WHO has endorsed either giving 1 dose of HPV vaccine or 2 doses. That just came out from WHO. And so we obviously hope that this will potentially double the amount of HPV vaccines available. In addition, with support from the Gates Foundation, a number of companies in China and India have developed generic HPV vaccines. They're ramping up production. Several of them have had pre-qualification from WHO, and so we hope that this will lead to a decrease in price. We've certainly seen the effectiveness of bulk purchasing to bring the price down. Both Gavi and PAHO have done excellent jobs in terms of negotiating a lower price, in both cases less than $10 a dose for the original quadrivalent vaccine, and we'd like to see this bulk purchasing extended elsewhere around the world, particularly in those countries that are no longer Gavi eligible. We have seen, however, that the nonavalent vaccines are largely being used in upper income countries, whereas the quadrivalent and the bivalent are more commonly used in low and middle income countries. So we hope that as the generic HPV vaccines become more available, that there may be second generation nonavalent vaccines actually tailored to the HPV subtypes in each country. I did want to say a little bit about what we've observed in terms of delivering HPV vaccination. Certainly school-based vaccination programs seem to be more effective than clinic-based vaccination programs. We've also seen in the strengthening of adolescent health platforms, because there are a number of vaccines that are appropriate for adolescents, including HPV. And so certainly strengthening adolescent health platforms is another effective way to make sure that girls are vaccinated. Finally, in this area, health communications is critical. There have been a number of examples, both in Rwanda and in Malaysia, of a 2-year preparation time to educate community leaders, teachers, religious leaders, parents about the importance of cervical cancer and HPV vaccination as a way to prevent cervical cancer, followed by real-time monitoring of social media to combat misinformation. Turning now to universal healthcare and cervical cancer control, it's important that as we develop cancer control programs, as we develop expanded universal healthcare programs, that we ask whether they're covering the cost of screening, whether they're covering the cost of follow-up, because the cost of colposcopy, biopsies, ablation, LEEP, conization, and pathology can be substantial and can prevent women from getting the appropriate follow-up. We need to ask the question whether the insurance programs cover the cost of imaging, hysterectomy, and pathology for women found to have invasive disease, whether they cover the cost of, whether the insurance covers the cost of radiation therapy. And we've certainly seen from the data that Professor Ogilvie presented that we also need to be looking at the out-of-pocket expenses to patients, including transportation, lodging, food, childcare, lost wages. Turning now to the management of women found to have invasive cancer, we know the importance of accurate diagnosis and staging. This includes pathology, imaging. Certainly at a minimum, we would hope to have that individuals would have a CT scan of the chest, abdomen, and pelvis, followed by a presentation to a multidisciplinary tumor board and timely initiation of treatment. The treatment can be surgical at the earliest possible stages. There have been some excellent studies showing that neoadjuvant chemotherapy can shrink cancers down to the point that conization is appropriate. Total hysterectomy, again, for early stage disease, or radical hysterectomy for more advanced disease. For locally advanced disease stages, stage 3 and 4A, then platinum-based chemoradiation should be the standard of care. This includes both external beam radiation as well as brachytherapy. With treatment needs to be linked to effective symptom management. We need to empower the doctors and nurses caring for women with cervical cancer to assess and manage the symptoms, both those associated with cancer and those associated with cancer treatment. We need to be able to evaluate an individual's need for psychosocial support, for spiritual support, and or financial support. In the area of survivorship, we need to better understand how best to help women return to normal family life and work lives. And finally, we need to make sure that we have palliative care available for women unable to access treatment and for women with persistent or recurrent cancer. There are some excellent guidance documents coming out from a WHO consultation that was co-chaired by Professor Eric Krakauer at Harvard and Dr. Elena Fedorova at the World Health Organization. All they published their recommendations in 3 guidance documents. All are open access. I've got the citations here. It's the Journal of Clinical Oncology, Global Oncology. First is estimating the palliative care needs. Secondly, an essential package of palliative care. And third, an augmented package of palliative care. These are excellent documents. I participated in some of the discussions and was impressed with their thoughtful approach. So I highly recommend these documents. That completes my talk, and I'm happy to turn over turn things over to Dr. Keith Martin. Thank you.
Thank you very much, Dr. Trimble, Dr. Ogilvie, Dr. Garcia, Dr. Maza. This was a fabulous discussion, evidenced by the very dynamic chat that's going on. And thank you, everybody online, for your extraordinary questions. We were going to go to a discussion amongst ourselves, but we're not going to do that. We're going to go to your questions. But there's one question we have to ask, and I'm going to pose it to Dr. Garcia, and perhaps Dr. Ogilvie would like to add any points. In regard to the importance of vaccinating not only girls, but also boys. And should boys also be vaccinated for not only reducing cervical cancer rates in girls, but also broader cancer control objectives, including the growing problem head and neck cancers in men and women. So Dr. Garcia, please.
Yes. So for cervical cancer control itself, I mean, it's quite important to vaccinate girls and be sure that we catch up, I mean, all the young women, okay? However, there are certain populations, and we have seen this, that because of a history of abuse, etc., they are really scared about vaccines that are only directed to girls because they think that those are directed to modify their fertility, for example. And adding boys can increase the acceptability of the vaccines, okay? And that will be one reason, for example, in which vaccinating boys or having gender-neutral vaccination could also increase the acceptability. However, there is very clear data nowadays that there are benefits, direct benefits for boys and for men of being vaccinated for HPV. So one of them had to do with the fact that nowadays there are more cases of oropharyngeal cancers in men that are median age, okay? And those could be benefited, okay, or could be prevented by HPV vaccination, because we know that HPV is associated not only with cervical cancer, but in the case of men with oropharyngeal, anal, penile, and cancers. So in Peru, one thing that we did is to make these things more efficient. In 2017, when I was Minister of Health, we decreased the number of doses from 3 to 2 doses, and that allows us to save some money. So we left everything ready in order to start vaccination with boys, but it took some time because of all these political instabilities. So finally now that there is evidence and WHO recommends not 2 doses, but 1, we even have more savings, because once the money has been left aside for vaccines, right, you have to use it. So this year, boys are going to start being vaccinated, and we hope that that will help, especially in certain populations in which there are some concerns about the acceptability of the vaccine.
Yeah, thanks, Patty. I don't have anything to add. I think the key thing here that Patty said is, if you are focusing on elimination of cervical cancer, the priority is getting coverage in girls. But if your community is suspicious or has concerns, or it's stigmatizing to have a girls-only program, then you need to have a gender-neutral program. But there's so many benefits beyond that, that obviously a gender-neutral program is the best way to go. Thanks
so much. And so a question right now from our listen, it's been extraordinary to watch people from all over the world, Cameroon, Nigeria, Haiti. Really, this is phenomenal attendance to the webinar. Dr. Trimble, this question's for you. Then I'm going to ask a different question, Dr. Mazza, to you. Dr. Trimble, Dr. Rahul Jindal is a surgeon. He's in India right now, and he said that, I don't know if you're aware of this, that there's a new Cervavac HPV vaccine that's been created in India by the Serum Institute. It's $2 a dose. Is this a game changer? If I don't know whether this is too new, but is this something that is going to change the accessibility issues?
Yeah, well, we certainly hope so. You know, and the Serum Institute of India was one of partners at with the Gates Foundation in terms of trying to make a generic HPV vaccine. So we hope that as this vaccine gets approved by regulators in India, that it will be taken up into the routine immunization program in India as it achieves pre-qualification from WHO, then it will be available potentially to other countries. And certainly $2 a dose is much better than $110 a dose, which is what this vaccine cost when it first emerged. So I agree. I think it could be a game changer once the approvals come through.
Great. Thank you very much, Ted. Dr. Mazza, this question is from Laura Slimp, and she wanted to know, how did PAHO break down the silos between clinical-based prevention and immunization services? How did you break that down to have a more holistic, effective distribution?
Well, I think it's important to see the different strategies that are done in each country, right? Because we have huge differences even within each sub-region. Unfortunately, in the PAHO region, we have a great vaccination overall, great vaccination rates and programs. And we do need to acknowledge that with HPV testing, we've seen that school-based programs are a great way to do and introduce the vaccine. That's why, unfortunately, during COVID, we saw a significant decrease when children could not go to school and do that. But, you know, it's a challenge to go from health promotion and the importance of vaccination to actually a secondary prevention program with HPV testing or just screening overall, because they're very different barriers that you need to overcome. So even though we're having great success as we expand, it's one of the biggest challenges because there's a lot of cultural barriers that change from country to country and subregion to subregion regarding access to a pelvic exam and you know, having that support. And I saw so many great messages about the importance of educating men also as part of that shift that you're talking about on how do we actually increase the support and the adherence to management, not only for vaccination, but now for screening in our populations.
Thank you very much, Dr. Mazza. And I think, so Dr. Garcia, do you want to say something?
Yeah, just one thing. You know, the fact that the schedule for HPV vaccination has changed from 3 to 2 to 1, I think can change the history of what we are doing. We used to say school-based because then we have the kids there and it's ideal, right? I mean, you can go to school, but you can do also vaccine festivals because you just need, and that's one thing that we do in Latin America in several countries. So Saturday, Sunday in all the parks, you can see the health professionals vaccinating. Since you have to vaccinate them only one dose, you don't need any follow-up and that will be effective. So I think it's changing, I mean, game changers. Right now, it's the possibility of having vaccines that are cheaper. So that's one. But the other one is the fact that it's only one dose. And that means that you can use it in different ways. And I think one thing that PAHO has worked very well with our countries has been to promote, we have like vaccination weeks to catch up, but most of the countries, we have these campaigns or festivals. Okay, so where outside, you go outside on a Sunday or a Saturday and in the parks, you will find a little camp, a little tent with a health worker vaccinating to all those who have not been vaccinated. Kids, now they can be adolescents and also adults or elderly people for flu or COVID or whatever. I think those are the kind of things that we need to start thinking in other regions too.
Thank you, Dr. Garcia. Now, this time has just flown by, and we have we could do an entire session just on your questions. So I really apologize that we won't be able to get to them, but our panelists are going to have a moment to make any final comments before I close, and we'll go in reverse. Again, I really apologize for all of you. Your comments and chats have been really extraordinary, and you've interrogated this important issue so well. Dr. Trimble, please go first. And
Yeah.
then we'll have Dr. Garcia, Dr. Ogilvie, and Dr. Mazza will close. Please, Dr. Trimble.
Yeah, I just want to emphasize the importance of sharing best practices and learning from one another, as well as I want to commend the three panelists who joined me on this panel for their work in outreach to communities to understand what communities want, what communities need, what interventions will be effective in their own communities. And I think we have three people who've done a great job in that regard. Signing off.
Thank you, Dr. Trimble. As always, we really appreciate your enduring support in our common efforts to reduce the burden of cancer globally. Dr. Garcia, sorry, please.
Yes, I just want, maybe before I finish, I would like to answer a couple of things that I think were important, right? Somebody was saying like, well, but we cannot access HPV testing and it is very expensive. Nowadays, there are several alternatives. The ones that we were using in the Andean region it's the HPV Care HPV test, okay? Which is a type of molecular test, but it's the cheaper alternative, okay? And actually, it costs $7.5 test. And I think, and we can get it in our region through the strategic fund from the Pan American Health Organization. So the fact that they buy a lot, they help us to drop the prices and we can buy it. So one thing that maybe needs to be studied, okay, is how PAHO, which is for the Americas, can share with other arms of WHO in the regions, the AFRO, for example, how they could have a strategic way of buying tests in a bulk so prices can go down and they can be accessible. I'm leaving my email because they are asking questions about how to train, et cetera, and this is something, I mean, this is work in progress. We're starting to write the papers, et cetera, but if you have questions, send me an email. But I think, and I just want to leave this with hope, because technologies can really help us to change what we are doing. And we need to understand what are the incentives of people. So the qualitative research, understanding how to introduce things within health systems in countries, understanding the differences and what people think are critical. Thank you.
Thank you, Dr. Garcia. Please, Dr. Ogilvie.
Thank you. Thank you for this great panel. You know, for me, the key thing is when you're thinking that screening is really important. I'm so excited about the vaccination. I led the 2 versus 3 dose trial. So I'm so excited, and part of the 1 dose panel. So I'm very excited about that. But we do need to still prioritize screening to save those lives. And I think between, you know, some of the innovations, particularly with HPV self-collection, really take advantage of the benefits of HPV over PAP screening, and there's lots of clinical trials that show that, particularly as a screening test and the negative predictive value, and the easy accessibility. I think the opportunity there is that regions can really shape it for this specific region. So that's some of the work that we've done in Uganda has really shown what would work in that region. And I think you have to be very region and community specific. One of our colleagues online has talked about African voices. I want to be really clear that Dr. Carol Naksiga, who is my co-PI, was just not able to make it today. So she and Dr. Orem are leaders in this. So yeah, I'm pleased to be able to present on their behalf. But I think what's really critical is that we, going back to what Patty said and what Ritu said, is we have operational research that really can help guide our programming, because each region has different issues and it needs to be assessed in that way. So thank you very much.
Thank you, Dr. Ogilvie, and all the great work you're doing back home at the University of British Columbia. Much appreciated. Dr. Mazza, you get the penultimate word.
Thank you. Thank you so much. And again, just thank you for the invitation and allowing us to come together and share with so many people. It's unfortunate we were not able to answer all the questions. I've been sharing in the chat some links regarding HPV vaccination, HPV screening, and I agree, you know, in order for us to eliminate, without vaccination, there's no elimination of this disease. And without screening, you know, we won't save lives of this and next coming generation. So we can't not work on this. As challenging as it can be, we see that HPV testing is possible. We need to ensure that we can get tests to people. Like Dr. Garcia said, we have that through the strategic fund, and through the revolving fund, we're able to also provide lower cost vaccines for member states. So it is something that we can do. It's within our grasp. And I think that in 7 years' time, many of the countries will be able to reach this elimination goals. It's a huge challenge that the world has put into doing this, but I think it's something that's within our reach. We know what causes the disease. We have the tools to prevent it and treat it in a early manner. So we should all come together, because something that's very clear to us is that there's no way we're gonna eliminate this disease if we don't have the work from everyone: civil society, government, and international agencies, and all the universities, of course, that are key to make this possible. Thank you again for the invitation.
Thank you so much, Dr. Mazin. We're neighbors in Washington, D.C., so CUGH looks forward to deepening our work with PAHO and all the great work that you're all doing down the street from us. Really, you've all been outstanding. So on behalf of all of us at CUGH, Dr. Ogilvie, Dr. Garcia, Dr. Mazin, Dr. Trimble, thank you very much for really an outstanding presentation. That this is about people's lives. You all deal with it. All of your work is intended to save women's lives. And the loss of 340,000 women's lives every year is an unconscionable and preventable loss. And you know, your comments at the end, Dr. Mazin, this is affordable, preventable, doable. It's smart politics, as Dr. Garcia knows well. And Dr. Ogilvie mentioned that we've got the research, the operational research to back it up. So it's up to all of us here who are listening to this and taking it back home. Please take back what you've heard here. Please take back and use it. Get the political will to support this, these efforts and interventions that you've heard today. And I would encourage you to attend our conference coming up in April in Washington, D.C. You can register now at www.cugh2023.org. This issue will be dealt with there. In addition, before the conference, our virtual sessions, which are free for anybody to see, will take place from the 3rd to the 7th of April, including 3 sessions from the National Cancer Institute that Dr. Trimble helped to start many years ago. And again, this would not happen without the great work of my team. I'd like to thank Jenna Smith, who leads this particular effort with great support from both Dalal Najjar and Julia Zeigel. With support also, UNFPA has been a great support of this effort. So we thank everybody from UNFPA who's really been supporting our efforts to work with them to eliminate cervical cancer. And to you, our attendees, thank you for being here, because this wouldn't happen without you. We hope to see you in Washington, D.C. at our conference or at our next webinar. Thank you for joining us. Have a wonderful day.